Mr. Genereux, so give it a couple more minutes. Okay, so welcome everyone to meeting number 19 of the House of Commons Standing Committee on Health. We're operating pursuant to the orders of reference of April 11th and April 20th, 2020, and the committee is meeting for the purpose of receiving evidence concerning matters relating to the government's response to the COVID-19 pandemic. So in order to facilitate the work of our interpreters and ensure an orderly meeting, I would like to outline a few rules. Firstly, interpretation in this video conference will work very much like in a regular committee meeting. You have the choice at the bottom of your screen of either floor, English, or French. If you will be speaking in both official languages, please ensure that the interpretation is listed as the language you will speak before you start. And for example, if you're going to speak English, switch to the English feed. If you're going to switch to French, switch to the French feed. And this will allow for much better sound quality for interpretation. Before speaking, please wait until I recognize you by name. Once the questioning starts, the witnesses may feel free to respond as appropriate. When you are ready to speak, click on the microphone icon to activate your mic. Should members need to request the floor outside of their designated time for questions, they should activate their mic and state that they have a point of order. I remind that all comments by members and witnesses should be addressed to the chair. When speaking, please speak slowly and clearly. And when you're not speaking, your mic should be on mute. If you have earbuds with a microphone, please hold the microphone near your mouth when you're speaking. And should any technical challenges arise, please advise the chair or the clerk immediately, and the technical team will work to resolve them. It may be necessary by times to suspend the meeting in order to deal with such technical issues as arise. Before we get started, can everyone click on the screen in the top right-hand corner and ensure they are on gallery view? With this view, you should be able to see all of the participants in a grid-like manner, and it will ensure that all video participants can see one another. So I'd like to now welcome our witnesses. From the Canadian Cardiovascular Society, we have Dr. Paul Dorian, Representative and Department Director, Division of Cardiology, University of Toronto. From the Canadian Health Coalition, we have Melanie Bernard, National Director, Policy and Advocacy. And from the Canadian Nursing Association, we have Michael Villeneuve, Chief Executive Officer. And finally, from Diabetes Canada, we have Russell Williams, President, and Kimberly Hansen, Executive Director, Federal. And coincidentally, this week is National Nursing Week, and 2020 is the 200th anniversary of Florence Nightingale's birth. So I'd like to take a moment to recognize all the nurses working so diligently in the face of this pandemic and who do critically important work every single day in all areas of care. So I'll start the opening statements with Michael Villeneuve, the CEO of the Canadian Nursing Associations. Mr. Villeneuve, please go ahead. 10 minutes, please.
Thank you very much, Chair. Can you hear me okay, Erica? Okay, good afternoon. Thank you, Chair and members of the committee, for inviting the Canadian Nurses Association to appear today. Pardon me. I've worked in health systems for more than 40 years, 37 of those as a registered nurse, and I've had the honor of serving as the CEO of the Canadian Nurses Association since 2017. I'd like to acknowledge that I speak to you today from my home in Mountain, Ontario, which is the flattest place in Ontario, I think, despite the name, and I speak to you from the unceded territory of the Algonquin and Anishinaabe people, and CNA House in Ottawa also sits on this territory, and we're grateful to be invited to share this space. There's more than 431,000 registered nurses, licensed practical nurses, registered psychiatric nurses, and nurse practitioners in Canada, the largest number of providers in our health systems. CNA is the national and global professional voice of Canadian nursing, and we represent 135,000 members across all 13 provinces and territories, and of course, many of our members also live in Indigenous communities. Wish I were speaking before you today about a less sobering topic, but that's not the world we live in right now, and as I saw it expressed recently, we went to sleep in one world and woke up in another. I know that the health and safety of the public and the nation's healthcare workers are uppermost in your minds and certainly in ours. And the pandemic clearly escalated broadly and as rapidly as a brush fire. And we must maintain our guard in supporting Canada's nurses and all healthcare professionals who are confronting and mitigating its impacts. We're in a situation unprecedented for all but the few who can still recall the flu pandemic of 1918 to 1920. And we've all been scrambling in response. Canadian Nurses Association appreciates the measures that have been taken by all levels of governments across the country to tackle this problem and minimize the spread of COVID-19. And we've particularly benefited from the incredible and courageous leadership of our public health professionals, including the nurses who are so integral to that sector. We appreciate the strong communication from Dr. Tam, who leads the Public Health Agency of Canada, and we've had good communication back and forth with Health Canada, including with the Minister, and of course with Dr. Tam and her team at the Public Health Agency. We thank all of them as we thank you, members of Parliament, who are members of this committee. We speak with nurses all the time, and certainly very purposely each week we talk with them and poll them. And I want to take a few minutes to share with you highlights just of a few ongoing issues, and then I want to spend the last 5 minutes talking about a larger system issue that I think we need to tackle. So what are the ongoing issues of concern for nurses? You've all heard about personal protective equipment concerns, and 3 months into the pandemic, that still remains a bit inconsistent across the country. And it remains our position at CNA that those decisions around the use of personal protective equipment should be driven by evidence and the clinical judgment of the people using the equipment, and not availability or fear of shortage. So that's been an ongoing issue that seems fine in some places and less so in others. Second issue around testing, the WHO has urged for large-scale testing, but we realize that COVID-19 testing in Canada still falls behind some other nations, and nurses are concerned that without this information, the recovery efforts will not be informed by evidence. We're concerned about mental health right across society. This has been very scary. Nurses in particular are facing significant challenges to their mental and emotional well-being as a result of the COVID pandemic response and recovery. And we are continuing to advocate for access for all healthcare providers to mental health services at no cost to manage their emotional and mental health coming out of this. We're particularly concerned that just as many of us will have a chance to step back at some point, a little bit away when the pandemic settles, as we assume it will, or in waves, nurses and doctors and the people in the healthcare system are then going to have to pick up the backlog of all the undone surgeries and so on, and really be very, very stressed during that time. We're working with the Canadian Medical Association, the Canadian Institute for Health Information around determining the impact of COVID-19 on the health of healthcare workers. And we would urge governments to fund the tracking of that important data, which is a long-standing issue. Nurses, while they talk about concern about their own safety, one of the top issues they mention is vulnerable populations, and we're concerned about people who are more at risk for the spread and impacts, including many Indigenous people, particularly in remote settings, and people in congregate settings, such as prisons, shelters, and the homeless. My final point, before I speak about long-term care, is that given the lessons of history, we would urge a very guarded, evidence-informed, cautious, paced reopening of services across society. We're concerned that the virus is very much alive, still spreading, not well understood, and may well sweep across society in successive waves. We understand there's huge economic implications, but that has to proceed very carefully. Let me turn to a couple of larger issues that are really of concern to the Canadian Nurses Association and to nurses. Due at least in part to the very aggressive Flatten the Curve campaign, which Canadians have, by and large, taken part in, our hospitals have, in the main, been spared the devastation of our counterparts in China, Italy, the United States, for example. But at the same time, The pandemic has laid bare the crippling lack of standardization, funding, strong leadership, appropriate staffing, training, equipping, and so on of people who deliver services in long-term care and home care sectors. And these vulnerabilities have been well known for 20 years. As a result, just 20% of COVID cases in Canada are in long-term care, but they account for 80% of the deaths. And we understand this is the worst outcomes globally. While our health systems have many strengths, a series of robust investigations since 2000, things like the Romano Commission, have generated a now very familiar litany of places where we need to shore up. And we can name them all: pharma care, home care, mental health care, long-term care, and primary health care based on need and not on the ability to pay. And we're seeing some of those weaknesses play out now. The outcomes of COVID-19 in long-term care this spring are part the result of decades of neglect of that sector and a growing mismatch between the level of care required by the people who live there and the human resources deployed to care for them. Many of the patients, I told you I've been around for 40 years in the business. Many of the patients living in those nursing homes now with complex continuing ongoing conditions would have been in a hospital 20 years ago. And it's hard for people now to imagine that in nursing homes 20 and 30 years ago, people still drove their car to it, right? So those people now are managed in home care. And as we've shifted really complex care away, the response in long-term care has not been concomitant with the demand going in there. So the rising pace, volume, and complexity of care that's been shifted from hospitals to nursing homes also has coincided perversely with a decline in the proportion of regulated nurses in that sector. Fewer regulated nurses, fewer clinical educators, fewer social workers, fewer occupational therapists. It's a story of fewer and less, and it has a dramatic impact on the people working there who are largely unregulated and delivering 80 to 90% of the care. The workforce there is dominated by caring, loving, well-intended healthcare aides and support workers who just are not backed up with the sorts of professional nursing and other resources they desperately need. It's heavily dominated by women, often racialized women, who are paid low wages and often precariously employed. And you've heard the story. They have to cobble together 2 or 3 jobs or work a lot of overtime to make a living wage. And COVID-19 has just really exploited those weaknesses. In the final report of the National Expert Commission that CNA conducted in 2011-2012, we laid out 9 practical recommendations to address many of the same issues brought up by Commissioner Romano, Senator Kirby, and others that could drive better health care outcomes, better care, and better value for taxpayer dollars, and many of them have gone unheeded. If there's any silver lining in this, we have certainly seen that we can do things differently. We have flipped around primary care, for example, so that much of it can be done by telephone and virtually. We know that hospitals are partly empty because of canceled surgeries, but we see the emergency room wait list problem has declined, for example. Hallway medicine disappeared. And we believe that we have the capacity to address those problems and sustain those results. We can't go back because we know now we can do it differently. Meeting demands of older adults requires major changes to the health system and certainly some immediate attention to personal care assistance and nursing expertise in those facilities in particular. We have to reimagine aging in this country, including home care, institutional long-term care, end-of-life care, and then put those bold changes in place we know are needed. So to wrap up, I would say, I guess COVID-19 has shown us very strangely in the year of the nurse that nurses are an important force for delivering better health. And they've certainly shown that they're dedicated to the people of Canada, even when they're worried about their own health and safety. Clear information, adequate supplies, additional support for health system and its workers are needed, and they're going to be needed in the long term. It's not going away tomorrow. As the chair said, we meet today in the Global Year of the Nurse and Midwife during International Nursing Week and on the eve of Florence Nightingale's 200th birthday tomorrow. And perhaps ironically, after 200 years, we find ourselves talking like Nightingale: wash your hands, clean the environment, gather good information to make your decisions. This week, we've set aside years of planned celebrations, as you can imagine, out of respect for the tens of thousands of nurses who are out there working at points of care this very minute, some of them even coming out of retirement to do so. They've answered the call. So on behalf of CNA, let me close by thanking you for including us, and I ask that you place nurses in leading roles in the analyses of COVID-19 responses lying ahead. Listen to them. They have practical, smart information, and know that we will work with you to identify and deliver the best evidence to help governments and health systems make the changes that we need and implement real change. Thank you very, very much.
Thank you, Mr. Villeneuve. We go now to the Canadian Cardiovascular Society, Dr. Paul Dorian. 10 minutes, please.
Merci beaucoup, Monsieur le Président, et bonjour à toutes et à tous.
Sure. Welcome, everybody. I would like to first of all thank all the members of the committee for the opportunity to represent the Canadian Cardiology Association. We are pleased to have this opportunity to take up some challenges concerning some patients suffering with heart disease during this COVID-19 period and coming up with solutions.
Representing the Canadian Cardiovascular Society, our 2,500 members include cardiologists, cardiac surgeons, and scientists. We provide specialized and ongoing care for close to 3 million Canadians living with heart disease, and we're very grateful for this opportunity to present to the committee. What I'd like to do first is to describe the consequences of the pandemic on heart patients, and then suggest some recommendations to help improve patient care in the short term, as the first wave of the pandemic unfolds, and in the future as subsequent waves of this or other infections hit. At the front line, what we're observing is that sick people are not seeking the care that they should. You've just heard that a moment ago. When the COVID pandemic struck in Canada, we were quick as a community to enact strict measures to contain its spread, including widespread stay-at-home messaging. Canadians have been very good at listening and adhering to this advice. So much so that we've seen a significant reduction in patients seeking emergency care for all illnesses, but particularly for cardiac care. Although the numbers seeking care are way down, heart attacks and other emergencies have not stopped occurring. We believe that our patients perceive hospitals to be overloaded with cases of COVID, of course, correctly or incorrectly, and they're afraid of coming to hospital and being exposed to the virus. As a result, patients with emergency needs are staying at home and waiting to see if symptoms go away, and some, unfortunately, are dying while they wait. When they finally do seek emergency care, they have often delayed so long that their conditions have become more serious and harder to treat. This is something we've observed over the past month or so. The later that patients present for treatment, particularly for heart attacks, the less we can do for them, and we're seeing more complications, which are harder to treat. Secondly, while we deal with COVID patients, wait lists for canceled procedures have skyrocketed. To be ready for an anticipated surge, hospitals have appropriately, we think, reallocated resources and freed up beds. But in our effort to be prepared, hospitals have been operating under capacity. Since March, across Canada, a huge number of planned life-saving procedures were postponed. As an example, as of March 15th in Ontario, there were about 2,000 patients waiting for valve procedures and 450 for defibrillators. As of May 3rd, that wait list had grown to 2,500 valve cases and 680 defibrillator cases. These wait lists have unfortunately resulted in patients suffering, and indeed, some have died. My colleagues speak of their valve patients who have been accepted for procedures dying at home before the surgery could be done. So we've avoided a surge in COVID patients, but the backlog of heart patients waiting for treatment has surged. Wait times are now longer than they've ever been, in years in some cases. A major complicating factor, we think, in planning for and delivering care has been the lack of real-time data. Without real-time data, we have no way to understand how local health service supply and demand trends, and to make regional comparisons to inform decisions about allocation of services, and to inform our patients about opportunities to seek care. Recently, we've collected some hospital data that there have been drops as great as 40% per month in several provinces since March in the number of patients coming to hospital with a kind of heart attack called STEMI, the most serious type of heart attack. This has been observed in other countries as well. But we don't have all the information needed to interpret what's happening. Were there fewer heart attacks occurring? We think probably not. Did patients delay in calling 911? Did ambulances make fewer and slower trips? Did patients in the field arrive at hospital already deceased? And was care in hospital delayed because of COVID precautions? We unfortunately don't know. It's frustrating to note for us that much of the data to answer these questions exists and is collected already in real time, but is trapped in data collection systems that don't talk to each other technologically, or that prevent data from being shared due to geographic boundaries or for legislative, contractual, or policy reasons. Collectively, these barriers prevent health data from being used for the very reason it's collected, to enable care through evidence-informed decision-making. We must note that our national resource, CIHI, Canadian Institute for Health Information, has responded as best as it can throughout the pandemic to supply data. However, CIHI itself is limited by the same barriers I've just mentioned. In this moment, we need data in days, whereas the typical time frame for obtaining data is months. We're eager to help resolve these challenges brought on by the pandemic. And in looking to contribute solutions, the CCS has several that we would like to propose. First, we think we need to refine public messaging in the face of a pandemic. If we can anticipate that stay-at-home orders result in heart attack victims not seeking or delaying care, public messaging needs to be more precise and widely shared. The federal government, through the Public Health Agency and Health Canada, are well positioned to lead this, and the CCS is willing to help develop and spread these messages. Second, public health officials, health service planners, and care providers need shareable, real-time data. Current information that can easily be shared would enable more nimble actions in an emergency. We would know where and whether scheduled and essential procedures might still take place based on need and in balance with local demands. And with better access and sharing of data, we can reduce the impact of national health crises on cardiac and other patients while still providing crisis-related care to those affected. In the current situation, COVID-19 patients have been appropriately prioritized. The consequences for other patients, unfortunately, have been higher than would have been ideal. Without data, we don't think we can do better next time. Our ask of the government and the colleagues and this committee is to take the lead to improve the sharing of real-time data. This could be done, for example, by forming a national expert working group to oversee coast-to-coast streamlining of data access and sharing. This expert group would work with federal and provincial health data stewards to identify and resolve the long-standing legislative and technical barriers to rapid shareable information. Their mandate would be to enhance coordination by locating all the data sets and getting them to talk to each other. I emphasize this data is already being collected. This committee would also help aggregate data so it could legally and virtually be all in the same place. And through understanding of what's going on locally and comparing to what's happening in other regions or provinces, we can accelerate best care and resource use. In the long run, we think that improved access to data can refine healthcare system delivery. Care can be more equitably available and higher in quality. Care pathways could be more efficient. Virtual care can be deployed in the most effective ways. Low-value care can be identified and reduced. Savings can be reallocated to where resources are needed the most. And if we get this right, we can expect to see better patient outcomes during, but also beyond any crisis. For those of you on the committee,
Pour les membres du comité,
you will know that the need for access to high-quality data and national comparative reporting is a call the society has been making for some time, and we are very grateful for the support that we received from our partners and supporters in government. The COVID crisis has shone a light on access to data as a major impediment in responding to a pandemic. Drawing attention to this at the highest possible policy-making level is a key contribution that the CCS aims to make. I'd like to just briefly list the actions that the CCS has already taken to support the pandemic. So thus far, in the last 6 weeks or so, we've developed, published, and shared clinical guidance for health professionals who care for cardiac patients affected by COVID. We've developed and widely shared clear messages stating that people experience chest pain or other signs of heart attack should urgently seek care. And we've done this in partnership with the Heart and Stroke Foundation of Canada and others, but I think we can do more. We've also funded research to learn more about COVID and its effects on patients with heart disease. The CCLs will undertake to continue to do all we can to help in this crisis, and I'd like to signal to the committee that we're willing and able to consult and provide guidance on any matter, if we can be of help, concerning Canadians living with heart disease in light of this pandemic. We will all have the most success working together if we align our efforts and support one another. Merci, and thank you for this opportunity, and I look forward to your questions.
Thank you, Dr. Doran. We go now to the Canadian Health Coalition. Ms. Bernard, please go ahead, 10 minutes.
Bonjour tout le monde, bon après-midi, good afternoon. Thank you for the invitation to appear before you today. The Canadian Health Coalition has been working for over 40 years to protect and improve public health care in Canada. We are a national, non-partisan organization made up of healthcare workers, unions, community organizations, seniors and academics, as well as affiliated coalitions in the provinces and one territory. Canadians are very grateful to have a universal public healthcare system that provides care based on people's needs and not on their ability to pay. This system has been put to the test over the past few months. The COVID crisis has highlighted the incredible strengths in our healthcare system, as well as some persistent gaps and challenges.
Ms. Bernard, pardon me, could you hold your mic closer to your mouth, please? Thank you.
Let me know if that helps. The COVID crisis has highlighted the incredible strengths in our healthcare system, as well as some persistent gaps and challenges. As we slowly begin recovering from this pandemic, we have an opportunity to rebuild our healthcare system to be even stronger and more responsive to the evolving needs of Canada's population. Today, I'll be discussing 3 areas that require the federal government's attention: pharmacare, funding, and seniors care. As you may know, Canada is the only country in the world with a universal public healthcare system that doesn't cover prescription medication. As a result, millions of Canadians have been falling through the cracks. Before the COVID-19 pandemic, 20% of Canadian households were struggling to pay for their medication, either because they didn't have a drug plan or because their drug plans were inadequate. 1 million Canadians were having to choose between putting food on the table and buying the medication they needed. These numbers have increased exponentially during the COVID pandemic. The mass layoffs triggered by the pandemic have left millions more Canadians struggling to afford their medication without work-based drug plans. The need for universal public pharmacare has therefore never been more urgent. 2 years ago, this committee studied this issue in detail. I know a few of you served on the committee at that time. After holding 23 hearings with nearly 100 witnesses, the committee recommended that Canada adopt a universal, single-payer public pharmacare program that would cover prescription medication in the same way as doctors and hospitals. Over the past 50 years, countless government and academic reports have all made the same recommendation. Most recently, the government's Advisory Council on the Implementation of National Pharmacare, led by Dr. Eric Hoskins. The Hoskins report from 2019 provides a blueprint for how to build this essential new program. The government must implement its recommendations immediately. Universal public pharmacare would save money while saving lives. When people skip their medication because they can't afford it, the technical term for which is cost-related non-adherence, they end up getting sicker and visiting the hospital and the doctor more often. That's something we want to avoid in normal times, but during this pandemic, it's absolutely critical. Research has shown that removing out-of-pocket costs for the medications used to treat just 3 health conditions, diabetes, cardiovascular disease, and chronic respiratory conditions, would result in up to 220,000 fewer emergency room visits and 90,000 fewer hospital stays annually. This could save the healthcare system up to $1.2 billion a year, just for those three conditions. Canada's current patchwork of drug coverage is inadequate and inefficient. There are over 100,000 public and private drug plans across this country that each offer different types of coverage. Many plans limit the amount that people can claim per month or per year, and many include expensive deductibles and co-payments that make medications unaffordable. The current system is also unsustainable. Canada pays the third highest prices among OECD countries for prescription medications, and spending on medication continues to rise. The number of drugs on the market that cost more than $10,000 per year has more than tripled since 2006. Canada currently spends more on medication than it does on doctors. Universal public pharmacare would allow us to limit this spending by negotiating lower drug prices through bulk purchasing. This new program would allow Canada to save $5 billion every year. Families will save on average $350 per year, and businesses will save an average of $750 per employee per year. Last fall, nearly 200 national and provincial organizations signed a joint statement calling on all parties to work together to implement universal public pharmacare within this government's mandate. We simply can't wait any longer to implement this program. Canadians are suffering, and some are dying prematurely because they can't access their medication. The government must implement pharmacare immediately as part of its response to the COVID crisis. Now is also the time for the federal government to reaffirm its commitment to public health care. Public health care is our best defense against the COVID pandemic and other health crises. Regrettably, our healthcare system has been eroded over decades through systematic funding cuts and privatization. Even in normal times, the system is functioning at capacity. The federal government must increase health transfer payments to the provinces to expand the capacity of public healthcare across the country, both in normal times and in times of crisis. The 10-year health accord from 2004 guaranteed the provinces an annual 6% increase to Canada health transfer payments. When that accord expired, the federal government reduced the annual increases to nominal GDP or 3%. We've known for years that this is simply insufficient to keep the system running effectively. At least a 5.2% escalator is needed just to maintain existing services. In addition to long-term increases to the CHT, extra funding will be needed to handle the backlog of surgeries and services that have been put on hold during the pandemic. Instead of turning to the private sector to address this backlog, the federal government should support the provinces to implement inexpensive public innovations to reduce wait times, such as centralized wait lists and team-based care. The government must also protect our public healthcare system by actively enforcing the Canada Health Act. Many private, for-profit healthcare companies have taken advantage of this crisis to expand their markets, particularly in the area of virtual healthcare. Many of these companies are violating the Canada Health Act by charging patients out of pocket or billing private insurance companies for virtual doctor's visits. In addition to raising concerns about the privacy and security of patients' medical information, this is draining resources from the public healthcare system. It is also threatening the foundational principle of equity that underlies our public healthcare system. The government must take action to prevent further erosion of this system and ensure that patients always come before profits. I think we would all agree that one of the greatest tragedies of this pandemic has been the widespread devastation in our long-term care homes. The suffering of residents, staff, and their family members in recent weeks is simply unfathomable. According to recent estimates, approximately 80% of all COVID-related deaths in Canada have been in long-term care facilities. Our deepest sympathy goes out to all those who've lost loved ones during this crisis, and we express our ongoing gratitude to all frontline workers who are putting their lives at risk every day to help care for patients in need. Although we may not have been able to prevent the COVID pandemic, We could have limited its devastating impact in our long-term care homes if we had implemented fundamental changes to this sector sooner. My colleagues from CUPE testified before you last week on this issue, so my recommendations here will be relatively brief. To ensure equitable access to safe, high-quality care, we must bring long-term care and home care into our public healthcare system. Over the past several decades, we've seen widespread privatization in this sector, in part because these services aren't currently covered under the Canada Health Act. We need new, dedicated federal funding for long-term care that is tied to national standards of care. These standards must include things like minimum staffing levels. The federal government must support the development of more public, long-term care facilities and home care services, since abundant research shows that public, not-for-profit facilities provide higher quality care than private, for-profit facilities. All public funding should go towards patient care, not corporate profits. We also need a national health human resource strategy to help recruit, train, and retain high-quality care workers. These workers must be paid decent wages and guaranteed stable, full-time employment. We can significantly improve patient care by improving the working conditions for staff. The seniors and people with disabilities living in long-term care facilities and relying on home care are counting on us to rapidly make these changes. We must not let them down. We can't undo the harm that has been caused by this crisis. But if we implement these changes, we can help prevent similar harm from occurring in the future. Let's learn from this experience and rebuild a public healthcare system that we can all continue to be proud of. A system that provides the high quality care that everyone in Canada deserves. Thank you.
Thank you, Ms. Bernard. We go now to Diabetes Canada. Mr. Williams or Ms. Hansen, please go ahead, 10 minutes.
Merci beaucoup. Thank you very much for the opportunity to present today. I thought I would start off sharing some of the cases that we receiving on our information line, people looking for help. One example is a woman who phoned us, and her father, who is an insulin-dependent type 2 person with diabetes, was living in a long-term care home. And with the concerns, and we've heard that today, created by the COVID-19 pandemic, our caller wanted to bring her to live with her, but she needed advice of how to manage his diabetes. Another woman with type 1 diabetes who struggles to keep her blood sugar within the recommended range reached out to us. She works in maintenance in a hospital, and she and her physician were worried about her risk. Despite the advice of our medical team and her employer refused to modify her work arrangements so she could reduce the risk of catching COVID-19. We needed to help her convince her employee to make accommodations. We also heard of someone who had just been diagnosed with diabetes and released from hospital. A new diagnosis of diabetes is overwhelming at the best of times, but especially in this environment. Discharged with insufficient information and support, this person was scared and confused and uncertain of what to do with their diet, their medication, and glucose monitoring. And countless of other people have reached out to us, people who have problems with their injection sites or have to ensure how to manage their diabetes with added problems like kidney disease. Tout ça pour dire que nous avons
All that to say that we have seen a spike in demand for Diabetes Canada services.
Diabetes is large and a growing burden in Canada. Diabetes, as you know, is a leading cause of heart attack, stroke, kidney disease, amputation, and treating the disease will cost over our healthcare system over $40 billion a year. It's a disease that disproportionately burdens vulnerable Canadians, including newcomers, Indigenous peoples, seniors, and those with lower incomes. In a moment, we'll talk about how the pandemic posed an even larger threat to people with diabetes and associated conditions. But I wanted to share with you some of the examples of how it's affected Diabetes Canada. Physical distancing measures, the economic impact of the pandemic have reduced Diabetes Canada's revenue by more than 50%, like a lot of charities. And we had to temporarily lay off more than 50% of our staff. Some of them we've been able to bring back because of queues, and we appreciate that, but we won't be able to keep them. Our revenues will continue to be negatively impacted by the pandemic for the foreseeable future. That directly affects our ability to serve people affected by diabetes. However, the needs of the people with diabetes for trustworthy information, education, and advocacy are even greater than ever before. And we are rising to meet that challenge. We are providing timely and evidence-based resources and tools to our community about diabetes and COVID-19, including frequently updated websites, weekly Ask the Experts videos, and webinars in 12 of Canada's most commonly spoken languages, educational webinars for healthcare providers, and offering patient resources and support via our 1-800 Banting line, via which people can get personalized expert medical advice from diabetes leaders. We are also collaborating with government all during this pandemic to support healthcare policy development and implementation, because issues will continue post this pandemic.
Pardon me,
to ensure
Mr.
diabetes
Wilson.
medication support.
The interpreters
Sorry,
the interpreters are having trouble hearing. So, yeah, thank you.
Okay, sorry. This connection
And
is better.
also I would point out that your sound is very choppy, so you might take extra, speak extra slowly. And thank you.
I hear it as choppy. Listen to you too. Apologies. We are collaborating to ensure diabetes medication supplies and devices remain available and affordable. We are amplifying announcements from provincial governments that support people with diabetes, and we're continuing to work on our national strategy that Kim will talk about later. We continue to work with governments on prevention, nutrition policy, pharmaceutical policy, which affect the daily lives of people with diabetes. We must ensure that the total ecosystem of the world of diabetes is balanced going forward, and there are not effects caused by policies which negatively impact our community. In these respects, like most other charities, we are stepping up during this time with dwindling resources. Health charities in Canada is a $670 million sector, supporting 2,500 employees and almost 3 million patients. We support well over $155 million of research and 1,300 investigators. Supporting research through this is going to be very important. And patient needs services and supports more than ever as a result of capacity and stress that you've heard about today in our healthcare system. Yet charities must increasingly meet these needs without the help of volunteers, prevented from serving by physical distancing, and reduced donations of households and businesses as they grapple with the economic impacts of the pandemic. For these reasons, we are united with other health charities in calling for a direct investment from the federal up to $28 million per month, which represents the monthly revenue decline of our members we've been witnessing since March 2020. The investment would allow staff and volunteers to focus efforts on patient support, restarting our fundraising efforts, and protecting our gains in research. I ask for your support in calling for greater federal investment in this vulnerable sector. We desperately need increased support. For example, the Emergency Rent Assistance Program is not geared to help charities at this point. Many of these charities have facilities across the country, and other programs do not seem to respond to the day-to-day operational needs of charities. Many of our charities have to increase the care and are filling gaps in their healthcare system caused by physical distancing and isolation. Now I'd like to ask my colleague, Kimberly Hansen, to speak about the impact of COVID-19 on people with diabetes. Merci beaucoup. Thank you.
Merci beaucoup. Many people with diabetes are high risk for COVID-19. Well, as we are learning more about this new virus, research is showing that while having diabetes doesn't make someone more likely to catch COVID-19, it makes the consequences more serious if they do. Early research shows that people with diabetes are approximately twice as likely to require hospitalization and intensive care as those without, and about 3 times as likely to die of COVID-19. Because of this, many Canadians with diabetes are very worried about the pandemic. Like diabetes, COVID-19 is a disease that exploits health inequities. The more socially and economically disadvantaged a person is, the more likely they are to suffer from diseases like diabetes, heart disease, and high blood pressure, which put them at greater risk to COVID-19. People in poorer socioeconomic circumstances can also be more exposed to infection. They may be unable to self-isolate due to insecure labor conditions, which do not allow for teleworking or provide statutory sick leave. They are more likely to experience overcrowding in their living arrangements. The pandemic has brought out in even sharper relief the critical necessity of addressing underlying health inequities to preserve the health of our citizens. COVID-19 has also highlighted serious gaps in data and challenges that can exist due to unintegrated health systems across provinces and territories. The critical necessity of making evidence-informed decisions about allocating limited healthcare resources and implementing health policies during the pandemic has highlighted the lack of health data sharing and systems integration that has plagued our healthcare system for years. A lack of easy ways to share best practices and harmonize healthcare across provinces and territories has contributed to the burdens of COVID-19 being shared unequally among different provinces and their citizens. Conversely, the tremendous progress that is being made to close these gaps in response to the pandemic show how collective will and sense of urgency can produce real results in record time. Provinces are leveraging and sharing medical information as never before, and planning to use apps and digital tools to share and track chronic medical conditions. From coast to coast, doctors are offering virtual consultations that would have been considered impossible just 2 months ago, and which are a key tool in preventing the overload of our emergency healthcare system. Practices such as these, leveraging virtual care, establishing and using medical data repositories and registries, optimizing and continuously improving patient care pathways, all are key tenets of Diabetes 360, Diabetes Canada's nationwide strategy, which this committee has recommended for implementation. Developed by 120 stakeholders over more than a year of rigorous effort, Diabetes 360 contains evidence-based recommendations aimed at improving patient outcomes. It will enhance the prevention, screening, and management of diabetes to achieve better health for Canadians. It will reduce unnecessary healthcare spending by billions of dollars, improve the lives of millions of Canadians, and protect Canada's productivity and competitiveness. We believe that in light of the pandemic, Diabetes 360 is more relevant than ever. Its implementation will support public health and deliver on the need for collaborative, value-based healthcare models and a multidisciplinary, comprehensive approach to healthcare. The billions of dollars in savings that will be realized by our healthcare system when we implement Diabetes 360 are an example of the effective use of public dollars to combat chronic disease. Given that diabetes is one of the most empirically measurable chronic diseases, implementation of a comprehensive strategy to prevent, diagnose, and treat diabetes based on data on patient health outcomes can serve as a useful test case for managing other chronic diseases. With the 100th anniversary of the discovery of insulin in Canada in 1921, right around the corner, we urge governments to embrace Diabetes 360 now. In summary, Diabetes Canada, like all Canadians, is pivoting rapidly to adapt to the new reality we are faced with given the COVID-19 pandemic. We are serving people with diabetes now more than ever and will continue to strive to do so even with limited resources. But we, along with other health charities, need additional support from the federal government to do so. A key measure that the federal government should take in response to the pandemic and in anticipation of 2021 is to implement a nationwide strategy to address diabetes and the burden of chronic disease in Canada in general. Diabetes Canada stands ready to collaborate with governments to end the diabetes epidemic once and for all. Merci.
Thank you, Mr. Williams and Ms. Hanson. We will start now with our questioning. We will do 3 rounds of questions. I would also like to remind everyone that the committee is meeting for the purpose of solely of receiving evidence concerning matters relating to the government's response to the COVID-19 pandemic. So I would urge members and questions to be, do your best to stick to that area. So we start now with Mr. Generou. Mr. Generou, please go ahead. 10 minutes. Or sorry, I keep doing this. 6 minutes. Thank you.
It's always higher than what I'm actually allotted, Chair. So I always take it until you correct yourself. Thank you, everybody, for joining us today, and also in celebration of International Nurses Week. Certainly, from our side of the table, want to recognize that and appreciate the Chair's comments. First questions to Mr. Villeneuve, if you don't mind. Is there a protocol that's consistent for PPE for nurses across the country?
In theory, there is, Mr. Genereux. So one of the challenges we faced in this is if we look at advice coming, say, from the World Health Organization and then the Public Health Agency of Canada, it's quite consistent. The advice has been very, very helpful. The challenge we have is when you filter it down then through however many lenses at the regional health authority level, the employer, like the organizational level, the level of the manager within an organization, that seems to be where things fall apart a little bit. And it's not unusual. It's in a federation, in a profession with multiple regulated categories and lots of people influencing it. So in theory, yes, I think it's pretty clear. And our advice, it has not really changed. And I can tell you from my own experience, if in a neurosurgical intensive care unit, if I went to do a procedure, the nurse is educated and the doctor to know what you need for that procedure. So we expect employers, governments, employers, everyone to have the materials there, and you get what you need for that procedure and use your clinical judgment. So we think nurses are quite capable of making those decisions. What we have been concerned about in some cases is the interpretation of what seems like a fairly straightforward, if this, then that. And part of that is 430,000 nurses, 13 jurisdictions, hundreds of employers. It gets a little bit mired.
And then, so we had the head of the Ontario Registered Nurses Union indicate that they need 9 million masks a week. Do you have is that unique to Ontario, or is that pretty standard across the country to keep them safe and healthy?
I don't know the exact number, Mr. Jenner, but the issue with it is typically in a situation of plenty, you would change that quite frequently, right? That material, you don't leave it on for very long, and you've seen some of the pictures of nurses with some damage to their face and so on. So 9 million, I don't know if that's the right number or not in each province and territory. What we have heard from physicians, nurses, and so on is some concern about using it too long, not sure if I can use it again. What happens when you don it and doff it and do that sort of thing safely? And that's where you've heard probably the same thing. I was told to wear one mask for 4 hours, whereas when I was in the ICU many years ago, changed it, room to room to room and so on through the day. So our concern has been that the decision should always be based on evidence and the need, and not a sort of rationing around a fear of what might be a shortage in the future.
So we, as the chair indicated, we're looking at the government's response to COVID-19, and obviously in preparation for any potential other pandemic, we want to make sure that we get everything right and be able to present that back to the government and to the particular individuals involved. For your organization, when was the first time you were contacted by the minister or the public health agency with regards to a response, whether it be PPE or any other issue at the time? I guess from that kind of January, February time frame.
I actually made the first call myself, and I'm going to say it was around January 20th. I should have checked this. It was about the third week of January, and we were watching, saying, what, the great question of science, what is going on here? So I called Dr. Tam's office. I happen to be a member of her public health, her advisory committee of health professionals, and said, could we just talk with someone? And I had a very good meeting within 24 hours with her team, and asked the question, is there something we can do? How can CNA be helpful here? What do you think is going on? And we had, from that day forward, really excellent communication with the Public Health Agency of Canada and with Health Canada.
So then if at that point in time, we were hearing stories already about the lack of personal protective equipment. Was that something that you raised in that January 20-ish phone call?
It didn't come up in that first call, Mr. General, but it's because what the Public Health Agency said is the same thing that the minister said, which was helpful. When we said, what can we do? The answers back were, please tell us what nurses are telling you, so that we have a very good sense of what's going on at points of care across the country. So no, it was not in that very first conversation, but I have to say it was very prominent in many conversations thereafter, although now I see it seems to be sort of shifting. We're not hearing quite as much about it as we were in the first 4 weeks, in the last 3 or 4. But still pockets of it. And other places, I can tell you, I happen to be a board chair of a hospital in Ontario, and was told by the nurses, we have every single thing we need, not a problem. So it's the unevenness of it that seems to be playing out. And of course, if Nurse Betty in Saskatchewan hears that Nurse Dave in New Brunswick has something different, it's confusing. Or if, as we heard in a case in another province, a paramedic and a nurse show up to do whatever they were doing, some kind of piece of care. The paramedic has the N95 mask and the nurse is told, you don't need it. So it's that unevenness in practice settings that's, I think, causes anxiety for people.
Thank you, Mr. Jenner. We go now to Dr. Pulaski. Dr. Pulaski, please go ahead, 6 minutes.
Thank you. And I'm going to ask my first question to Mr. Villeneuve of the Canadian Nursing Association. And by the way, I fully support everything you're trying to do with respect to PPEs. I'm a longtime emerge doctor and keep hammering away on that, please. Now, I wanted to talk about chronic care homes and the situation faced by people in those homes. Obviously, this crisis has really highlighted the plight of people working in those homes and people living in those homes. And so many of the deaths have been in those homes. So I wanted to ask you, Mr. Villeneuve, you talked about the need for bold changes. Would you didn't mention it, but would you support the call of QP last week, which was for a universally publicly funded chronic care program for all elderly in this country?
Yes, it's been our position for a long time, Dr. Pulaski, that long-term care and home care, when required, should be provided based on need and not the ability to pay. And that patchwork, we believe, the patchwork, one of our colleagues just testified, mentioned of the way long-term care plays out across the country, I think has not done well for seniors in the country. Our concern is that we jump immediately to inquiry or just funnel a lot more money in there and put more registered nurses in there or whatever the solution is. I think we need to step back, look at that population. What is aging in Canada going to mean? Because long-term care and chronic care doesn't just happen, as you know, inside bricks and mortar walls. It's in community centers, in primary care. It's part of end-of-life care. So I think we've had a terrible outcome. We need to analyze it and inquire, of course, but we need to step back, I think, take it up a level and say, what is aging in Canada going to mean for the 21st century? And how are we going to pay for it?
Okay, so yes, I totally agree. I think part of doing better in the future in managing a crisis like this means doing better in terms of providing services for chronic care. Now, I wanted to direct my next question to Ms. Bernard, Canadian Health Coalition, advocating both universal publicly funded pharmacare and presumably universal publicly funded long-term care. And the question arises as, can we afford one? Can we afford both? Now, I'm not an economist, but I gather, having listened to her, some of the arguments made were that having a there is economies of scale, and that buying in bulk reduces the cost of medications. She also made the argument that it's cheaper to have people take their medications and thus avoid going to the hospital than not taking the medications, going to the hospital, and that actually costs a lot more money. Presumably, a nationally funded pharmacare system would also allow the money that a lot of people don't get from their employer because it's going into their drug plan, would go into a nationally funded system. So I think the argument you would make is that it is affordable. Maybe it's even cheaper to have a nationally funded pharmacare program. Well, how about a universal publicly funded long-term care program? Is that something that's affordable? And again, presumably some of the money going into that system is money that currently individuals pay out of pocket as they become older, and if they have money, they have to pay to be in these institutions. So, do you think a national, universal, publicly funded long-term care program is financially feasible?
Yeah, so just going to the first point, so pharmacare, yes, as I mentioned, it would actually save us around $5 billion every year. We would be spending $5 billion less with the pharmacare program than we are currently spending without one. So it's not a question of can we afford it, it's can we afford not to have it.
That means we collectively, either through our plans, through our companies, through drug plans, or through the government plans that already exist. If you add those all together, that collectively we would pay $5 billion less if we had a national universal pharmacare program.
That's right. And we didn't just come up with those numbers ourselves. So there's a report by the Parliamentary Budget Officer that had some conservative estimates. And some people would say it would even be upwards of $11 billion a year. So it depends, I think, on the discounts that we could get on the prescription medication, but the savings would be substantial. In part, as you highlighted, because we would be saving money in other areas of the healthcare system as well. So the government would be saving money in that way. In terms of a universal public long-term care and home care program, I mean, I'm not an economist either, but I would say that it is really a question of priorities. I think we've seen the consequences of the current state of long-term care in this country. And I don't think anyone would think that this is acceptable. There's some early data showing that, or suggesting that there are more deaths in for-profit long-term care facilities than publicly run not-for-profit facilities. So again, it's a question of priorities. I do think when the government decides that an issue is going to take on an issue and make it a priority, which I think is what seniors really deserve here, then we can find the funding for it. Where there's a will, there's a way.
Time for a quick other question? No.
No, thank you, Dr. Pulaski. We go now to Mr. Theriault. Mr. Theriault, please go ahead, 6 minutes.
Merci. Merci.
Thank you very much, Mr. Chairman. And I'd like to thank all the witnesses for agreeing to appear before us today. It would be great if you could table your briefs and also add any additional comments you may wish to make in light of the questions that we're all asking today of you. My first question is directed to Mr. or Dr. Dorion. Sir, I found your testimony to be chilling. Now, we're talking about the heart. It's a vital organ that goes without saying. And many witnesses have appeared before us and said that already weakened, strained healthcare systems pre-pandemic are even more put to the test now in the midst of a pandemic. The system was barely able to cope with patient needs prior to the pandemic, and now they're completely overwhelmed. Now, I understand that you're making efforts to collate information, but in your opinion, how long will it take before patients end up having acute or chronic cardiovascular issues? How much will it take time to pick up the slack when it comes to cardiovascular services response? Well, as far as...
You hold your mic up better.
Oh, I apologize. En ce qui concerne les...
As far as intensive care is concerned, well, there's cardio infarctuses that have to be treated as a priority, and of course there isn't possibility to pick up treatments as of today. And patients just have to show up at the hospital when they are in a medical crisis. But as far as chronic problems are concerned, that aren't non-acute for valves and defibrillators, for example, unfortunately, the waiting list was long even before COVID, and I don't know how much time it will take to pick up the slack because we don't know exactly when we'll be able to get back to work. And undoubtedly, it'll be a progressive reopening for elective procedures. Now, elective doesn't mean per se that you can wait years and years to get your particular elective surgery. There are, in fact, casualties. There are people who die while they're waiting on the waiting list. Now, when will be the juncture at which we can proceed with as many elective procedures as we did pre-COVID? Well, I don't know how we're going to catch up with those patients that have been left by the wayside for a couple of months. We'll at least have to ramp up the number of procedures that we carry out, and it'll take perhaps months, maybe even years to catch up. Question. I don't know if you are abreast of the situation occurring in Montreal in some hospitals where there have been outbreaks. Now, when it comes to cardiovascular and cardiac care, for example, Sacré-Cœur Hospital, does that kind of outbreak make it even more difficult to provide care to non-COVID patients, if you will? Response: absolutely. I agree entirely with you. First, we've had to cut the total number of procedures that we carry out. Perhaps we do give precedence to some procedures, such as angioplasty, for example, for those who are in acute crisis. Secondly, we're not ready to reopen the doors and fling them wide open because, and there's, even when the doors are swung right open, there'll be a waiting list. Question: is there some kind of protocol that's been put in place to reassure patients who have appointments that were booked for the upcoming weeks, patients who have appointments in these hospitals where there are outbreaks that have occurred? How are things going to play out over the upcoming weeks in that regard? Response: I agree entirely. Things there are outbreaks from appearing from one hospital to the next, and what we say to patients is this. Really, it depends on the particular hospital. It depends on what amount of procedures, what capacity we're able to achieve. And to as greater extent possible, we try to ensure that there's there's cooperation between hospitals and hospital centres across all regions of Canada, so that we can transfer patients when we are unable to provide them treatment on site. Question: you seemed to insinuate that we might be able to recover quite quickly Do we already have, for example, electronic systems that are up to snuff right now? Response. Well, the vast majority of hospitals already collect data electronically. Now, the challenge, and they're collected at the respective hospitals, but they aren't necessarily shared between hospitals across regions and across provinces and territories. We need some kind of computer system, an automated system, and also a willingness to share data between hospitals. It's a question of willingness. It's a question of getting authority to discuss this kind of data, which may be sensitive because it's, as a rule, patient data, which is personal. But the problem is not that the data isn't being collected, but the data is, in fact, of a personal or private nature, and that it's not shared from hospital to hospital.
We go now to Mr. Davies. 6 minutes, please.
Thank you, Mr. Chair, and thank you to the witnesses. Dr. Dorian, I'd like to pick up that last point. You're one of, it seems, a long lineup of witnesses who have commented on the frustration of not having national standardized data. Would you support the call for national leadership backed up by federal legislation to make national standardized data collection mandatory?
Absolutely. I could not emphasize more exactly what you just said. Let me give you a specific example about frustration. There's been a lot of discussion, for example, on our lack of understanding whether patients, let's take acute heart attacks for a moment, or cardiac deaths. Just in parentheses, we know that from places that collect this data in real time and publish it immediately, there's been about a 40% increase in the number of people dying outside of hospital in Italy, in New York, and in other jurisdictions that have this data where they measure it reliably. Every time somebody dies outside of hospital, that information is collected in vital statistics because a death certificate is issued, or it's collected by the 911 paramedics. That data is available in electronic format within 4 hours of the event. We know where it sits. It sits in the individual's emergency medical systems data repository in each individual municipal jurisdiction. We know that data, when patients arrive in hospital, is collected in the emergency department. It's immediately abstracted and uploaded to a computer. That's how we know, for example, how many patients have COVID at any one time. When patients are admitted to hospital, we have that data within weeks, but we potentially could have that data within days. So the problem is not that highly skilled individuals are not collecting the data, but it isn't aggregated. And the ability to aggregate the data in 2021 is less an informatics problem than it is a problem of the willingness to share data and the ability to break down regulatory and privacy-related silos. We obviously have to be conscious of the need for privacy protection, but the 21st century privacy protection universe allows us to do that.
Well, I take it you're also speaking about metadata. We can find a way to extract just the raw anonymized data so that we have access to the raw numbers, right, and by protecting privacy.
I totally agree. So to give you an example of metadata, in the last 2 days, I've received personally metadata, so it's not privacy protected, from Alberta, British Columbia, and Ontario, and some from Quebec. This is from colleagues, but of course I had to be on the internet and make phone calls and send emails. But the numbers I gave you are in fact accurate numbers from the last 72 hours, but it's not the very efficient way to gather data to have an individual sending emails, as you can imagine.
Thank you. Ms. Bernard, a Toronto Star analysis of public data on long-term care homes in Ontario released just a few days ago found that residents of for-profit nursing homes in Ontario are far more likely to be infected with COVID-19 and die than those who live in nonprofit and public municipally run homes. In homes with an outbreak, they found that residents in for-profit facilities are about twice as likely to catch COVID-19 and die than residents in nonprofits, and about 4 times as likely to become infected and die from the virus as those in a public municipal home. In your view, what factors may explain this discrepancy?
The interpreter has to momentarily interrupt the service.
Let me know if you have trouble hearing me. So thank you for the question. That is the data that I was alluding to that suggested that for-profit facilities have higher fatality rates in their long-term care centers. So, an obvious example is staffing levels. Even at the best of times, when corporations are trying to increase their profits and they're accountable to their shareholders, one of the easiest places to reduce their costs is to have lower staffing ratios and less staff on shifts all the time. We've heard of equipment and supplies actually being locked up so that staff members can't access that equipment for basic things like cleaning, toileting, basic personal hygiene. Again, this is an attempt to increase the profits and reduce the expenses in these for-profit facilities. So that's in normal times. One can only assume that in times of crisis like this, these problems would just be exacerbated.
I'm wondering if there's some international experience, a recent study published by...
Mr. Davies, could you hold your mic up, please?
Yes, thank you, Mr. Chair. A recent study by the International Long-Term Care Policy Network found that Canada has the highest proportion of deaths in long-term care settings among 14 comparable countries, including Belgium, Denmark, France, Germany, Ireland, and Norway. Dr. Brian Goldman, CBC's White Coat Black Art, has called this a statistic that should leave Canadians mad as hell.
Mr. Davies, translation is having trouble hearing you. Could you hold it up a little bit more and
okay? Can I start again, Mr. Chair?
I'll back you off about 30 seconds. Go ahead.
Okay, thanks. A study has shown that Canada has the highest proportion of deaths in long-term care settings among 14 comparative countries, including Belgium, Denmark, France, Germany, Ireland, and Norway. Dr. Brian Goldman of CBC's White Coat Black Art has called this a statistic that should make Canadians mad as hell. In your view, Ms. Bernard, why is Canada faring in this manner compared to other countries on the international level?
That's a good question. I know we have on our board Dr. Pat Armstrong, who's one of the leading experts on seniors care in Canada. So she would be in a better position than I am to answer that question. And she just released a book in the fall that's looking at the privatization of seniors care in several different countries. I know, for example, that Norway is a good example to follow. They've had success in bringing long-term care back into the public system after it had been privatized for a long time. But I would assume that it's really in large part due to the vast number of private, for-profit, very large chains that have really taken over this sector in Canada.
Thank you, Mr. Davies. We go now, so that brings round one to a close. We start round two with Dr. Kitchen. Dr. Kitchen, please go ahead, 5 minutes.
Thank you, Mr. Chair, and thank you everybody for being here today. It's greatly appreciated. Mr. Williams, as I know you're aware, diabetes is a contributing factor of approximately 41,000 deaths in Canada per year. And we've heard many times in this committee about the health research has sort of fallen by the wayside, especially with this current focus on COVID-19. In fact, some clinical trials have halted indefinitely. I'm wondering, do you see any concern with respect to future diabetes research?
Yes, thank you for the question. We are quite concerned about our ability to continue supporting. As you know, we are quite committed to advancing diabetes research, but we're working with a number of other research partners to advance it. We're concerned about the research environment and the gains that we've been making, given that there's a pullback in terms of both private and public support. Now, everybody's trying to work through this, but as you look at 2021 being the 100th anniversary of the discovery of insulin, this is really the time that we should be focused very much on continuing to support diabetes research through partnerships, and that's with, we have a great partner with CIHR, we have great partners with some of the private corporations and private donors, but this is being challenged right now given the negative negative economic impact of COVID-19.
Last week, we heard from Dr. Wooters of the Healthcare Canada, who stated that 80% of our staff remain unable to continue essential research into cardiovascular disease, rare diseases, diabetes, and many other key diseases that kill the majority of Canadians. And part of it is dealing with the looking at, because their funding is training is all done in hospitals, they aren't able to access the benefits from the programs out there. Have you heard from any of your researchers on whether there are funding issues that when they're working within hospitals?
We're hearing that, and we're talking to them on a quite regular basis, and we're trying to figure out the impact throughout the country on that, because I think different people have been affected different ways, and we are pulling together a number of key leaders of that to have a discussion to get a better understanding of it. I could forward some of our data to you following this meeting.
Thank you. One last question, just quickly, and I've seen issues, for example, where there's shortages in Ramipril and metformin and medications that are used a lot by diabetics and type 1, type 2. I'm wondering, have you heard of or any other drug shortages that you might be aware of that are of concern?
In the beginning of this pandemic, we started to hear some concerns as there was some anxiety buying. People were, when they're thinking about spending time in lockdown and isolation. So we've monitored that very quickly, very regularly. We have talked to Health Canada, we've talked to suppliers, distributors, and pharmacists, and people are working through this. I'll ask Kimberly to add on an answer, but our sense is at this point, there is not a problem, but we are, there have been a few problems in a few pharmacies, but that seems to be working out right now for some of the medications that we're dealing with.
I apologize, Kimberly, because I appreciate you. I'm wondering if you could send us that comment to the committee, because I'm short of time and I just want to make sure I get some more questions in if I can. My last question is to Mr. Villeneuve, and I appreciate you being there. I can tell you that my wife is, when I first met her, was a pediatric intensive care nurse with the hospital of sick children. She became an intensive care nurse and flew air ambulance at Sunnybrook and in Ontario. So she has extensive experience and spent a lot of time training, as did I. And I realized the recognition of all that training that goes in for our healthcare workers. And in particular, when we're looking at long-term care. And the Minister for Employment and Workforce Development stated, we may create, working with the Home Care Workers Association in Canada, some kind of training so that people who aren't in those jobs right now, maybe people who are at home and unemployed, can take a shortened version of this training and be able to perform the less complicated tasks that are required of these homes. I'm wondering your thoughts on that and where you see that with healthcare workers in these long-term care facilities.
Thanks, Dr. Kitchen. And I was also an old Sunnybroker, so I appreciate the reference to your wife's work there. I think we want to be careful that we are not putting people into positions where they put themselves or patients at risk, residents at risk. And the danger in the sort of fast turnaround course is that they expose the residents to COVID, or they themselves get it. If we're talking about simpler functions, for example, such as a volunteer might do, push you from bedroom to a common dining room or something, that I think that makes some basic sense. But shortcutting the orientation and training time for something as important as very complex continuing care, I think we want to be careful.
Thank you, Dr. Kitchen. We go now to Ms. Sidhu. Ms. Sidhu, please go ahead. 5 minutes.
Thank you, Chair. Thank you all the witnesses joining with us. I want to recognize it's a National Nurses Week. I want to thank thousands of nurses who are working on the front line, to protect all Canadians. My first question is to Diabetes Canada. Nice to see you, Russell and Kim. And I really want to say thank you, Diabetes Canada, to work you are doing for Canadians who are living with diabetes. Kim, you know, a few weeks ago, we did a webinar for Canadian living with diabetes. During the webinar, we received many questions and comments from patients about an increased risk of diabetes complication due to COVID-19. They are concerned about different provincial and territorial approach for protecting Canadians living with diabetes, resulting in the health inequities. How can we ensure the efforts to protect Canadians with living with diabetes continues given the difficult circumstances? Do you think leveraging virtual care is helping? As Russell mentioned, in long-term care, he receives calls. What is your thought about that?
Thank you so much for the question, MP Sidhu. We really appreciate your support for diabetes always. We know that, as I mentioned in my remarks, that diabetes is a disease, as is COVID, that really exploits health inequities. And so responding to COVID, as well as ensuring the health of people with diabetes, will necessitate fundamentally addressing things like food insecurity and job insecurity in a general sense, ensuring that people don't have to choose between taking medication and feeding their children. We know that leveraging things like virtual health in the way that we have the last couple of months out of necessity can make care much more accessible to all Canadians, regardless of where they live, and can help reduce wait times significantly. I had an appointment with my specialist over the phone just recently, and instead of taking, more than an hour, it took 10 minutes and was very, very helpful. And so I think that can be a model for us moving forward. I think fundamentally what we're learning here is that the more we can act in coordination, one province to the other, learn from each other's best practices, leverage data, analyze it, and use it to make decisions about healthcare, the better that healthcare will be and the better that the health outcomes will be for Canadians. And those, as you know, are all behind our Diabetes 360 nationwide strategy.
Thank you. My next question is for Canadian Nurses Association. As we know, there are outbreaks in long-term care centers in Brampton South. One example, we have a Holland Christian Home long-term care, Grace Manor. During the labor shortage, the CFS, Canadian Armed Forces, are helping now during the COVID-19 situation. We need, I heard from the Canadian Nurses Association, we need fundamental changes in long-term care. So I want to know, how can the federal government work with the provinces and territories and with organizations such as yourselves and others to ensure that more nurses are able to help in our healthcare facilities, because our senior deserve a high standard care?
Thanks very much, Ms. Sidhu, for the really great question. First of all, it's very complicated, so it's hard to answer in a short couple of minutes, but so a couple of things. First of all, Canadians, and certainly nurses and CNA, do look to federal governments for strong leadership. And one of the things that federal government traditionally has done well is convene. So, I think there's a convening function, bring people together. We're a bit leery of 5 more years of talk, right? Because we've identified many of these problems for years. Some of them are as simple as 4 bedrooms, right? Or single bedrooms with a Jack and Jill bathroom, and it just spreads like a brush fire through those kinds of places. Some of it's old, outdated infrastructure. So if we had a modernization of the idea of what does long-term care look like, in places like sick kids and many other hospitals now, they're going to basically all single rooms because of this very problem. But the infrastructure of long-term care looks like 1955. It just has not kept up. And it might have been fine when people were walking around in their clothes and driving to do their shopping from those facilities, but it's not now. So I think we would say this, the federal government we turn to for the convening function, strong sense of leveling the playing field. What are the standards across the country? As a Canadian, what can I expect in Saskatchewan that I should also expect in New Brunswick? So it's a bringing together, development of standards function, and set the expectations.
Thank you, Ms. Sadu. Mr. Weber, over to you. Go ahead, 5 minutes, please.
Okay, thank you, Mr. Chair, and happy National Nursing Week to all of you, and in recognition to all our heroes out there, all our nurses and healthcare workers. My first question will go to Dr. Paul Dorian. Dr. Dorian, you mentioned in your okay, I'm just sorry, I've lost track here. Okay, you've mentioned in your presentation that these procedures for heart valve replacements and defibrillators and such have been delayed significantly, if not even canceled. So are people actually dying because of their inability to access heart surgeries and procedures due to the prioritization of COVID-19?
Doctor, could you hold the mic up, please?
Oh, yes, I'm sorry. Thank you for your question, MP Weber. So the short answer is yes. We don't have the exact numbers, but we have a number of cases. I just talked to a colleague from Sunnybrook Hospital yesterday who is in charge of data for the province of Ontario, and they've had 4 deaths on the waiting list in the last month. So the answer is yes. Unfortunately, these are quite ill patients, and we use the term elective procedure very carefully. These are individuals who need a procedure not immediately, for example, like an acute heart attack or somebody who's on death's door, but these are individuals who normally would be expected to have a procedure within somewhere between 4 and 8 weeks, are now potentially facing a wait list of months and perhaps even longer.
Wow. Yeah, we hear that quite often, even with an area that I'm quite involved in, that is organ and tissue donation. The fact that those have been delayed as well, people are dying, and that's just a shame. You mentioned, Doctor, about research briefly in your presentation as well, and how COVID-19 has affected heart patients. Maybe talk a little bit about the research that has been going on, if any, that you've heard of regarding the long-term effects of the heart due to COVID?
So those are superb questions. Absolutely, we would like to be able to help our patients understand both in the short term and the longer term what the consequences are to the heart of having COVID. We already know, this is of course no news to anybody, that if you already have heart disease, then your chances of getting sicker or sadly not surviving COVID are higher. We also know that a substantial proportion, probably a minority, but a large number of patients who have the COVID illness not only have respiratory illness, so they have troubles breathing and they have lung problems, but they also develop acute heart damage. We call that myocarditis. And there's at least 5 or 6 different kinds of heart problems that can happen with COVID. What we don't yet know is, in addition to what's the best way to treat the heart during COVID, but what is the long-term consequence? What should we be looking out for? How should we treat these patients to prevent worsening of their heart problems after they're discharged from hospital? There's some active research programs going on in Canada, sponsored by the Canadian Cardiovascular Society, and indeed worldwide, to answer those questions. If I may just emphasize that the only way to do this kind of work is to have rapid access to all of the data that we require to answer these questions. Otherwise, we're extremely inefficient in sort of going patient by patient.
Mm-hmm. Well, thank you for that, Doctor. And just on research, the Diabetes Canada, Ms. Kimberly Hansen, you also mentioned research and how diabetes patients are 3 times more likely to die of COVID. And you mentioned early research. Can you just elaborate on that, on what you've heard about early research in diabetes and the effects that COVID-19 has had on diabetic patients?
Well, we have...
Go ahead.
Apologies, Russell. The data that we have is quite early on, Mr. Weber. We have data that unfortunately doesn't distinguish between whether patients had type 1 diabetes or type 2 diabetes. It doesn't give us well-segmented data in terms of how many complications did that patient have and how perhaps what were their ages, et cetera. But what we do see from countries that had the pandemic earlier than we did and therefore are further along in their journey is that when somebody who already has diabetes catches COVID, they're more likely to experience that cytokine storm that can result in the kind of COVID that needs hospitalization. They're much more likely to end up in the ICU than somebody without diabetes, and consequently, they're more likely to experience a death as a result of it. So we need to learn a lot more about that in order to fully understand what that means. We're trying to sort of send Canadians with diabetes a clear message that they don't need to necessarily be afraid off the bat. They just need to take precautions like all Canadians in order to reduce the risk that they'll catch COVID-19. But it's important to recognize that diabetes does predispose people to a greater likelihood of a poor outcome if they catch it.
Right.
Thank you, Mr. Weber. Mr. Van Bynen, you're up next. 5 minutes, please. Mr. Van Bynen?
I had some difficulty getting my mic off mute. My apologies, Mr. Chair. My first question is for the Canadian Health Coalition, Ms. Bernard. Now, we've seen the need for a radical change in long-term health care because of the devastating effect that we've seen with COVID-19. And I understand that your organization has been looking at national standards for long-term care facilities. How would you propose implementing and regulating these measures, recognizing that there are a number of layers of jurisdiction that are involved in providing health care and long-term health care?
Yes, thank you for the question. So it is a bit of a complex question because of this overlapping jurisdiction. But as we, I should probably do this. As we have seen in other areas of healthcare, there is a really critical role for the federal government to play. In the Canada Health Act, we have some criteria that the provinces must meet in order to access federal funding. So there's no reason why we couldn't do something similar for long-term care, as I mentioned, having dedicated federal funding for that specifically, and then including these national standards that the provinces have to meet to access that funding.
I understand, and we've heard a lot about funding, but my concern is that there seems to be, or we seem to be pointing at organizational change, structural change, in order to improve the lines of communication for things like providing PPEs on a national basis. Is there a need for a different type of organization, or is there a need for structural change in the delivery of healthcare to make it more efficient and more effective, particularly in relation to these national emergencies, these pandemics? And how would we go about implementing that?
Yeah, that's a big question. I mean, the kinds of standards that we're calling for long-term care and home care would be really broad principles that as I mentioned, the provinces would be expected to meet. When it comes down to operationalizing those principles, that would most likely be done at the provincial or municipal level. So we would be looking for things like staffing levels, as I mentioned, the number of hours of direct care that each resident should be getting per day. So it would be really those kinds of broad principles and criteria that could be done implemented at the federal level.
Okay. Now, my next question then is to Mr. Villeneuve. Many nurses have been helping on the front lines through provincial telehealth programs, for example, and I'm interested in hearing your thoughts on the Prime Minister's recent announcement to expand virtual care during this pandemic and how initiatives like this can help nurses and other healthcare professionals during this time.
Thank you very much, Mr. Van Bynen. It's been amazing to watch, just as an observer, let alone being an RN and in the job I'm in, how quickly we were able to make that transition. And when we surveyed nurses, polled some of our members, 70% had moved to virtual care options in their practice. So we've known in nursing for quite some time that nurse lines, nurse-led care, nurse-led models of care, for example, very satisfying to the public, great outcomes, same or better as traditional models, same or less cost, as satisfying to the public. So we would absolutely strongly encourage more virtual care extends our reach with precious, there's short, not short, but there's not enough of us to do it all. So it does extend our reach. The visits are shorter. So we would absolutely strongly support it. One of the issues, though, that's been brought to us by our own members is you need a reasonable amount of bandwidth to do some of that. And that's become a problem across the country. And one of our nurse leaders in Nunavut, for example, told us just to do a Zoom meeting, they use up their entire month's worth of bandwidth, and then are paying by the minute and so on, going on from there. So the other pieces have to be put in place, but we would strongly advocate for more virtual care.
Thank you. My next question then is for Dr. Dorian, I understand your desire to make sure that we have leading indicators in data. What type of organizational barriers are you encountering in getting access to data in order that you can start using data as a leading indicator rather than a lagging indicator, so that we can be more proactive in how we deal with changes that we're observing?
Thank you very much, Mr. Van Buynen. That's a very important question. The only organization that I'm aware of in Canada that is allowed to receive data that's transported across provincial barriers is CIHI, the Canadian Institutes of Health Information. Different provinces have different strategies for collecting data from hospitals and individual practices and aggregating them intra-provincially. So we have the CIHI is a very effective organization, obviously with some limitations in terms of what they're able to do, particularly in sort of early or just-in-time data provision. They're doing it for COVID, but obviously it would be useful for them to be able to do that with other kinds of data. So some of the limitations are regulatory, the challenge of sending data across provincial lines. Within provinces, there are different kinds of challenges, and they're related to the sensitivity around data privacy. The fact that the data custodians are the individual agencies that hold the data. So for example, for cardiac data in the realm of COVID, we have data that's collected in ambulances, as I mentioned earlier, and that's housed inside emergency medical systems. These data are potentially not easily interoperable, but the biggest hurdles are not the operability in terms of the IT challenges. They're that the data custodians are not in a position to talk to other data custodians to share data. They just don't feel they have the regulatory and privacy wherewithal to be able to share data.
So what would that do?
Thank you, Mr. Van Buynen.
Okay, thank you.
We go now to Mr. Theriault. Mr. Theriault, 2.5 minutes, please.
Thank you, Chair. Dr. Dorian. Some children are going back to school, so they will be in the presence of potential sources of contamination by COVID-19. On the Quebec Heart Foundation, they say some signs related to the Kawasaki illness are similar to COVID-19. They're not always easy to distinguish between the two illnesses. The standard treatment from Kawasaki's disease was used in Europe for COVID-19, and some doctors believe that this treatment could be useful for COVID-19. What do you think about this? Thanks for the question.
More accurate, I deep apologies.
You hold up your mic as well again, please.
Okay, so deep apologies to answer this question in English, but for the sake of accuracy and brevity. Kawasaki disease is a rare disorder. It manifests in the heart as what's called coronary artery aneurysms and sometimes inflammation of the lining of the heart. We see this so rarely in Canada. We don't have a good sense of the best therapies, particularly for the COVID version of a similar illness. The standard treatment would be steroid therapy, like cortisone variants. We have absolutely no idea if this would work in COVID. There's some limited evidence that this therapy, when from some early reports in China, may be harmful in COVID patients. It's been used. So we are unfortunately flying a little bit blind as a community. We feel very badly that there's children that are affected, but these individuals are so infrequent that we really don't have any good data to help guide their therapy. If I may be permitted, I think this is yet another example where, in order to be able to give the best possible advice to our patients, whether it's pediatricians looking after children or adult physicians, it's absolutely imperative that we have the access to the most comprehensive and accurate and real-time data on all aspects of COVID as we can, so that we can aggregate this information and not be dependent on our individual minor experience.
Thank you, Mr. Theriault. We go now to Mr. Davies. Mr. Davies, 2 minutes and a half. Thanks.
Thank you, Dr. Dorian. We've already spoken of deaths that may be attributed to because cardiac surgeries weren't performed. The Toronto's University Health Network recently estimated that 35 people may have died in Ontario alone because their cardiac surgeries weren't performed. We know that thousands of other surgeries have been postponed or canceled to ensure enough acute or critical capacity in our hospitals for a possible surge of COVID-19. I'm just wondering, given those estimates, do you feel that we've gotten the balance right between providing continuity of essential care for non-COVID-19 patients and freeing up the hospital capacity needed to respond to the COVID-19 pandemic?
Thank you. That's a very important question that we talk about a lot, Mr. Davies. In retrospect, I think it would have been reasonable to have less surge capacity and have continued doing some therapies. But I think I would absolutely not criticize health care planners, public agencies. I think we did the best as a community we could, given the information we had available. I think what's really important is that we have accurate planning from today going forward. I think we understand much more now than we did 8 weeks ago. This is a very short period of time since we started this journey.
Yes.
I think what's really important on a go-forward basis is that we use whatever information we can get, and the more information we get, the better we can predict what the consequences would be of what I think we all agree now must be a ramp up in cardiac and other needed procedures, cancer surgery, other kinds of surgeries. To get the balance right will not necessarily be easy, but it will be made better by having the most accurate and comprehensive data possible. And this is not just looking forward for the next 2 or 3 months, but I think we have every reason to believe that we're going to have this careful balancing act for months and possibly years. So it puts quite a bit of pressure on public health planners, epidemiologists. So we need now more than ever to have a community-based, fact-based, evidence-based response to healthcare planning.
Thank you. And a quick question, Mr. Villeneuve, if I have a chance. Approximately how many Canadian nurses have been infected with COVID-19 to date?
I don't know the number today, Mr. Davies, but I can get you that information. Certainly, we've been concerned that by any infected, and it seems to us here in this province in Ontario that it has been in the long-term care sector that the support workers have been unduly affected. However, we're working with CMA, I think I mentioned Early Medical Association, and CIHI to try to gather that data and report it in a reliable way. One of our problems, as you can well imagine, is did the worker get it at work? Did they get it from a child outside? And how are we going to distinguish those sorts of outcomes? So I'll look for that information for you when we put our brief in this week.
Thank you, Mr. Davies. Now that ends round 2. We start round 3 at this point with Ms. Jansen. Ms. Jansen, please go ahead. 5 minutes.
Yes, thank you so much. I would like to direct my first question to Dr. Dorian. Now, as you mentioned, all this data is already being collected, and yet we don't have access to that information. Now, in our day and age where everyone's concerned about making science-based decisions, it does seem surprising that we do not have access to that information. Even more surprising, of course, since the 2006 SARS report was clear that we needed a real-time information sharing system in place to help with tracking cases in a situation like this. I know even here in BC, we're looking at excess deaths that can't be attributed to COVID-19, and that sort of data would help us better understand if our COVID-19 response was appropriate. Now, do you think that some regions are afraid to share that data for fear of liability issues, perhaps?
Thank you for that important question. I don't think it's necessarily a fear of sharing the data for liability, but there's certainly lots of appropriate questions about data privacy. I think individual data custodians, these are the individuals that hold the data, whether it's within hospitals or within regions or within provinces or within agencies like emergency medical care systems, for example, are understandably and appropriately concerned with exporting their data without being assured that their data, which involves individual patient information, will be kept private. So one of the concerns is privacy. Another concern is data interoperability. A third concern is that not a concern, but the limitation is that data tends to be siloed within jurisdictions, and we just don't have today the structures. It really needs to be an overarching structure, provincial or federal, in my opinion, that needs to bring together all these individual custodians, if you like, and have them work together so they trust each other with their data, right. And that the data can be federated in one location. We know that it's technically possible. The hurdles are jurisdictional and informatics based.
Wonderful. Thank you very much. Now I have a question for Ms. Bernard. You suggested that public long-term care facilities provide better care than private. And I know Amanda Weiss from QP made a similar bold statement a few meetings ago, which I also challenged. I'm wondering what science-based information you're using to make that suggestion, especially since we just have heard from Dr. Dorian that there is no pan-Canadian data collection system to support that kind of an assertion. Is this just one of those cases where if you say it long enough and hard enough, it becomes true? Because here in BC, we've had a private long-term care facility ban public health nurses from entering due to the fact that they were only given 2 masks and 2 gloves to ration for the month by our regional healthcare authority. Now, clearly the challenge long-term care facilities have are far more complicated than just being either public or private. Access to PPE has been one of the biggest fiascos our public health authority has had to deal with. Our national emergency stockpile system was severely mismanaged, making it very difficult for all nurses, including long-term caregivers, to be able to protect themselves and their patients from infection. Protecting our seniors should be our top priority. Now, do you think that the Toronto Star article you cite has been sufficiently peer-reviewed to be able to extrapolate such a bold assertion?
So respectfully, I mentioned that the private for-profit or public not-for-profit is a factor in terms of providing higher quality care. And that is not simply based on the Toronto Star article that Mr. Davies cited earlier. It's based on decades of academic research. And there's actually the Office of the Seniors Advocate in BC that also published a report just, I think, a month before the COVID crisis began.
So it's not just private versus public. I appreciate that's kind of what I was hoping to hear. That's awesome. And now I have a question actually for Mr. Villeneuve in regards to telehealth. I'm just wondering, I know I've tried before to call in to get, say, test results, and I always have to go into the doctor's office to get my results because of billing. And also when it comes to when I had kids and I would phone the emergency to see, oh, should I come in or shouldn't I come in? They would often say, well, if you don't know, you should come in. So I'm wondering if there might be a certain situation that we have in front of us that will keep us back from using telehealth more in the future.
Yes, I think thank you for the question, Ms. Jansen. I think if we cling to old patterns, that will be an issue. But we've seen certainly here the public seems willing to do this, seems satisfied with it. We've heard in many regions across the country, not just our polling, but from regional health authorities, that they've also moved to 70% virtual and more than half of that by the phone. And I think if we can get billing right, because I do believe physicians need to be paid just as nurses and others are paid. And if they're adequately compensated, I think we can make that shift. And I have to say, I'm an aging baby boomer now. I'm at the bottom end of the trail, and we want those kinds of services. We want those sorts of changes. So I believe we can make them.
Thank you, Ms. Jansen. We go now to Mr. Fisher. Mr. Fisher, please go ahead. 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses who are here sharing their expertise as usual. Dr. Dorian, you gave incredibly thoughtful remarks, and your responses to the questions were equally thoughtful. I want to thank you for that. And I've changed my direction, and I'm going with you because of some of the thoughtful things that you've had to say. We've been, I think, very fortunate in Canada. I think the Canadian public has generally bought into the public health message and done a pretty good job. You talked about refining public message, and your organization has offered to help, or would offer to help, develop and spread the message, the public health message. Putting words in your mouth here, but I think you said find a way to balance medical needs with coronavirus needs. You've acknowledged that the coronavirus patients are appropriately prioritized. And again, I'll repeat, my belief is that we've been very fortunate in Canada that Canadians have bought into public health. So again, going to you because of your thoughtful comments, I'm fascinated, and I would rather we could sit down and have a cup of coffee or a beer and talk for an hour and a half on this, but we get 5 minutes. And I know that you're going to only be able to touch on this, but if you were developing and spreading the public health message, what would it look like? Would it be similar? Would it be vastly different? I would feel confident if you were in that role based on the things you've said today, but maybe you could just touch on some of the things that you might have done if you were crafting that public health message for Canadians.
Well, thank you very much for your kind remarks. First of all,
microphone, please.
I'm sorry. Thank you very much for your kind remarks. First of all, I think we have a task to do as a community, and this includes physicians, nurses, all healthcare workers, and members of government, representatives of government, and that is to help patients figure out whether the symptoms that they have warrant emergency care or not. And that is true for COVID, and that is COVID-like symptoms, and that is true for cardiac-like symptoms. So the major challenge we have, for which there's no easy answer, is to make sure that we educate all members of the public that if they have severe symptoms, this could be shortness of breath or cough or high fever in the case of COVID, or it could be chest pain, or it could be paralysis in the case of strokes, that they seek emergency care immediately. We have the extraordinary good fortune in Canada of having a very well-functioning emergency healthcare system. And it would be an extreme shame, which is why it's so frustrating for those of us on the front lines, that patients who could benefit from immediate care in the fortunately infrequent situations where immediate care is necessary, that patients are foregoing that care. What that message should sound like exactly, I'm not exactly sure. The Heart and Stroke Foundation has come up with some specific instructions to patients, but the requirement, I think, would be to come up with some simple, straightforward, available in all the languages that all our Canadian citizens speak, messaging that would be widely spread to reassure individuals that emergency care is available if they just want to seek it.
Thank you, Doctor. Mr. Villeneuve, telehealth fascinates me, and I know we had some pioneers in Nova Scotia that were pushing for this for a long time, and see it maybe as one of the only good things to come out of the coronavirus thing is that we are now talking about telehealth and doing telehealth. Is it here to stay? Is telehealth going to expand? Are we going to utilize our medical healthcare professionals in a bigger way through telehealth in the future after coronavirus says goodbye?
I can't imagine us going back. Can't imagine the public would be satisfied going back, Mr. Fisher. Ms. Jensen mentioned it a few minutes ago. I mean, I think we're going to have to learn to manage how much risk are we willing to take on. So when Nurse Mike is on the phone talking to someone in the public, what is that balance of I can't see you, so I can't tell, but now we can see you. We're doing it right now, right? So the public's learned to work like this. Offices are closed. The country hasn't shut. Well, the country has sort of shut down, but society has gone on with great communication. And when we ran the National Expert Commission 10 years ago almost, I can remember then one of our business leaders saying, why do you people spend so much time to describe a wound when we all have a camera that we could show the doctor and click it, right? So we've made that leap, and I can't imagine now that the public or even docs and nurses will want to go back.
Anytime, Mr. Chair?
10 seconds.
10 seconds, I'll pass. Thank you. Thank you, folks.
Thank you, Mr. Fisher. We go now to Mr. General. Mr. General, please go ahead. 5 minutes.
Thank you, Mr. Chair. Back to Mr. Villeneuve. So you'd agree with me that one of the most significant challenges that nurses are facing right now is the lack of PPE, correct?
It's uneven, Mr. General, across the country, but I think it's an ongoing concern for all the healthcare workers.
Right. So I guess going back to when was it first raised by your association, the importance of having PPE and enough PPE on the front lines?
Well, you raise a great question because we sent a joint letter with the Canadian Medical Association and the Canadian Pharmacists Association fairly early on. I'll find that for you. It was the first public sort of statement we made in an open letter saying that we were concerned about mental health issues, as many of us talked about, but also about PPE. So it was early on because of the SARS experience. And it wasn't really so much a complaint as be aware that this is coming. It's spreading across the country, and people need the right equipment to protect themselves in this situation. But we were on it very early.
And again, we want to make sure that we're getting the best response possible for any future potential pandemics. So knowing that these sorts of things being raised early and often are certainly exactly what we're trying to get at.
Yes.
So then that brings me to what we've understood with the national emergency stockpile and how that was mismanaged. Was that something on the Nurses Association radar at all? Did you know about that until it was in the news?
Well, I think our concern, Mr. General, was the unevenness of it. So we heard, for example, we had heard from one source, for example, that there was masks sitting at an airport blocked that couldn't get through some hurdle of customs or something like that. I don't remember the specific date or detail, but it seemed to us like there was an unevenness about it. And of course, part of that we assume from our own research and talking with people is because some of these products come from places in other countries that themselves are shut down. So I think, a key lesson for this going forward, for all of us coming out of this, is personal protection, just as we do for firefighters and others, so that the stockpile is there when we need it.
And sorry, just to help me understand a bit of the unevenness comment, are you talking within jurisdictions or talking within products? What do you mean by unevenness?
Well, I'm particularly thinking of personal protective device masks here, and in different jurisdictions, different employers, different rules on different shifts. And I'm not trying to dodge the question at all, Mr. General. It's a problem in healthcare we often have, which is I think we should do it this way on the surgical ward, whereas this leader thinks we'll do it this way on a medical ward. And even within institutions, practices can be quite different.
So you meant one of my colleagues asked a question, Mr. Davies, about how many nurses have been diagnosed with COVID-19. We'd also be very interested in that. Can you confirm? I think you did, just to clarify, that most of the confirmed cases of nurses diagnosed with COVID-19 are in long-term care homes?
No, I don't know that. I'm sorry, I don't know. So I checked with my colleague while we were talking, and we will get that information for you this week.
And you don't have any ballpark, eh? Just kind of tide us over till then.
I would totally be guessing, but we noted in Ontario that among what I believe is 7 deaths of healthcare workers, not that it should come to death, but if we're counting the worst outcome, 5 were personal support workers in home care and long-term care, and 2 were custodial workers in hospitals.
So touching on mental health, I know you touched on it already, but what support measures should be provided now that weren't necessarily provided before for the nurses profession that, or I guess, should be considered in light of COVID-19?
We know from the Polarab, I believe last week, research that both anxiety and depression have risen across society. The level of burnout was about 40% among nurses before this even started, and I think it's pretty high among a lot of physicians. So we're taking part in a rapid review of the research, Mr. General, coming out of the University of Toronto to define what are the sort of top level mental health interventions that work. Is it a phone line? Is it one-to-one counseling? And then identify, which among those we think works the best. The issue then will be, can we get it to people quickly and without a high cost or without any cost? Because mental health care in this country is expensive. It was hard to get before all this.
Thank you, Mr. General. We go now to Dr. Jaksic. Dr. Jaksic, please go ahead, 5 minutes.
Thank you very much, Chair. And in view of the fact that it is National Nurses Week, my first question will be for Mr. Villeneuve.
La première question.
T-shirt at the ready. It's International Nurses Day tomorrow, and I will wear it with enthusiasm to celebrate our wonderful frontline nurses. And thank you so much for giving that shout out to public health nurses who are not quite as visible as the nurses on the front line. I know here in York Region that our public health nurses have just been working around the clock on contact tracing, which, as you know, is a very detailed type of activity and very time consuming and requires considerable skill, as obviously some people really do not want to disclose exactly what they have been doing for the previous 14 days. So going back to the issue of the mental health, the strain on our frontline workers, which I think is self-evident. My recollection post-SARS, certainly in the GTA, was that a number of nurses did take early retirement following the SARS epidemic, their work, the stress that they had been involved in. And I know the Canadian Nurses Association has been concerned about shortages in the nursing profession. So how are you looking? Are you thinking ahead to consequences post-COVID as to what that's going to look like from a labor point of view?
Yes, and I'll give a very brief answer around SARS. That I was happened to be stationed out of the country that year, so I wasn't very close to it. But I have colleagues who worked right in the middle of it at Mount Sinai, who even now, when you talk to them all these years later, they're so traumatized they can hardly talk about it. In our long-term care sector here, we have a colleague who reported from one of the homes. She volunteered to go in to help. 60 of the residents out of the 170 had died in the previous 3 weeks, and 8 had died that night. And she just looks completely haunted. And this is a 32-year-old, or I guess she's young. Everybody's young compared to me, but just a young woman, doctoral candidate, full of energy, and just looks defeated. And says now, and then got COVID herself as a result of the experience, and feels she doesn't even know if she can go back into it. So we haven't had the ICU decision making where I have to decide you get a ventilator and you don't, or we're taking you off one because you look like this one might do better, and all that horrible stuff that came out of New York and Italy and Spain. But we may have it hit harder in the long-term care sector, which I don't think we were. Even at CNA, I don't think it was as much on our radar that it would sweep through there. So we are, yes, concerned about what comes out of this. We're really concerned that, for example, in Ontario, it was suggested, I think it was Mr. Ford on Thursday or Friday, that the estimate for the catch-up for the surgeries that Dr. Dorian mentioned is 2 years. So who's going to do that? Like, if all these people are already working full-time, where are those surgeons and techs and nurses going to come from? So we are concerned, and we are also working with a different research team to measure some of the impacts of this on the workforce. Does it cause people to retire, to move, and change? So it's all sort of at this point a bit of a messy middle, but it's on our radar. And thank you very much for that question.
Thank you. And now my next question is for Dr. Dorian. I think many of my colleagues have been questioning the whole issue of why isn't the data much more readily available? CIHI has that responsibility in order, hopefully, to create some sort of national database that makes sense. You have referenced privacy concerns, and in fact, I remember when I was Commissioner of Health Services and Medical Officer of Health for York Region, I was the health custodian for 6 different data sets, and according to our legal counsel, I couldn't talk to myself. In other words, I couldn't cross-reference patient X in one data set with the same patient in another data set. To what extent have you talked to privacy commissioners to ensure that they understand that aggregating data analysis is just so vital for us to understand the science behind disease patterns, etc.? Have you had those types of conversations as an association?
Thank you very much for that question. So the answer is we've had some of those conversations. We work very closely with CIHI, and I just want to make sure that there's no misunderstanding. CIHI has been extremely collaborative and supportive of the kinds of efforts we do. They're limited by basically their budget, their bandwidth, their ability to collect and aggregate information. That's a challenge that we face together. They're also limited in that they have access to some data which is collected, inside hospitals, but CIHI doesn't have the mandate to collect, for example, emergency department data or data from long care homes, at least some data in physicians' offices, laboratory data, and so on. I think you hit the nail on the head when you said it's challenging to even be allowed to talk to yourself. My sense is that the firewalls that are up there are not because of anybody's ill will, but because of levels of concern, perhaps appropriate, perhaps not appropriate, that will only be surmounted if we can get all of the individuals and groups and the custodians into one room at one time with some leadership and direction from public health agencies, either at the provincial or national level, who will help adjudicate between these various concerns and come up with a single type of strategy. I think we have tried to have individual conversations with individual privacy commissioners, but I'm not sure that is the most fruitful way of trying to solve this problem.
Thank you, Dr. Jaksic.
Thank you.
We go now to Mr. Theriault again. Mr. Theriault, please go ahead. 2 minutes and a half.
Merci, Monsieur. Thank you, Mr. Chair. I cannot go back to the genesis of the CHLD situation in 2 minutes and a half, Madame Bernard, but you put your finger on a problem that has a structural impact on our organizations, on our health agencies. When you spoke about underfunding, especially the healthcare costs from 6% to 3%, it's one of the major lessons to be drawn from this pandemic. The experts are all saying so. A system that is put at risk. We realize that this sort of pandemic, where there were weaknesses, problems already, they become even more poignant in this situation. So I share your analysis on that. I think we have years of backlogs in funding. They have had a structural impact on this specific situation. That's a pandemic. Now, when you say over 80% of deaths in these health institutions in Quebec, that's quite serious. So I share that aspect of your analysis. It would be negligent not to draw that conclusion. We have to find funding that go beyond the systemic costs that are estimated at 5%. Now, I hope that everyone is full of goodwill in the system and that they worked with the means available in this underfunded concept. It doesn't really justify anything, but how can a national standard change something? What we need is money in the front lines and not necessarily an organizational system or a standard system that could make a link in some of these funding chains. Now, why a standard? If we require a norms, public norms in these health institutions, what would be the nature of those norms? Thanks for the comments. J'espère que j'ai touché le bon bouton.
I'm glad we're in agreement on the issue of funding. So I think the question was whether what the role would be for standards then, if we just need increased funding, why we need standards. So I would say that we need to have some consistency. People across the country need to know that they can rely on a certain standard level of care. Of course, there's a huge role for the provinces in terms of the delivery of that care, but I think to meet these basic standards is something that, as I said, we see under the Canada Health Act for other areas of healthcare, and we're calling for similar standards to be in place for long-term care and home care.
Thank you, Mr. Theriault. We go now to Mr. Davies. Mr. Davies, 2.5 minutes, please.
Thank you, Dr. Dorian. We've heard that one of the gaps that the COVID-19 crisis has exposed as well is the chronic drug shortages, which occur, I think, at all times, but have been particularly pronounced here in British Columbia. They've limited refills of all prescriptions to 30 days. I'm just wondering what you could tell the committee about your experience with drug shortages, if any, in your field of expertise.
This will be, I'm afraid, entirely anecdotal. I'm not aware. Again, I apologize for coming back to data, but we don't have any really solid data on the full spectrum of drug shortages. In my own practice, I work out of St. Michael's Hospital in Toronto. I've had more than a handful of situations where the medication that I prescribed was unavailable at the pharmacy that issued the previous prescription. We asked them to look around at other pharmacies. They couldn't find the medications. These are cardiac meds. And I was asked to think of a substitute. Often the substitute medications are not as effective. We're not talking about generic versus not. We're just talking about medication type A versus medication type B. So it is happening. I'm not sure within the cardiac realm that it's been a situation where the medication was completely unavailable in any place. We've had relative shortages inside hospitals. We've had information from our hospital pharmacy that we need to be very careful in the use of certain in-hospital medications, particularly some pain-killing medications, medications used in anesthesia, medications used in acute cardiac care. But I don't have any information to tell you that this has resulted directly in patient harm. It's just something that we need to be very careful about in terms of future planning.
Thank you. And last to you, Ms. Bernard, I think there's a bit of a question about what the relationship between universal single-payer public pharmacare might have to the present COVID-19 crisis. I leave last words to you to explain to the committee why you think there's a connection there.
Sure, thank you. So as I mentioned in my testimony, we've seen millions of Canadians losing their jobs during this crisis. And since the majority of people who do have drug coverage have it through private insurance through their employer, people have now lost that coverage as well. So in addition to people who are trying to function on reduced incomes as well. So all these problems have been exacerbated during this crisis, which makes this need for universal public single-payer pharmacare all the more urgent.
Thank you, Mr. Davies.
Thank you.
So thank you to all the committee for all your great questions, and most particularly thank you to all of the witnesses for sharing your time with us today, so much of your time, in fact, and also your expertise. So thank you. I'd like to just advise the committee that on our meeting on Wednesday, the Canadian Association of Retired Persons will be added to the panel. They will be sharing this time slot with the Council of Senior Citizens Organizations of BC. So this won't add on any time. So anyway, thank you, everybody. And meeting adjourned.